Professor Ashraf. So again, we have sometimes challenging cases that we can face in the outpatient clinic. We don't know how to make in this case. Like very high asymmetrical work, for example, post-traumatic, post-keratoplasty. Sometimes that you have a very good cornea graft, clear cornea graft, but the patient is absent. جاي يضرب البوس في العياده كالعاده وهو الكورنيا it's very clear لكن في very high cylinder ونحطه على الاوتوريفت تلاقي out of cylinder. Post refractive surgery whatever very high regression ولا في astigmatism عادي. After the index, not all cases of the index or rings have the good results and sometimes unpredictable. الحقيقه in such these cases we have faced a problem. We don't know that's how to brainstorming what is the solution of such these cases. Like this in regression of the first one, second one it's pellucid marginal degeneration, third one it's keratoglobus, the fourth one it is a scar after trauma. So the problem here we have a visual problems. I have to treat the irregular cornea and to treat all the associated refractive error, especially the high astigmatic cornea. So if we make a brainstorming how to visually rehabilitate of these patients, I need a safe, effective, highly predictable, and very good cost result for these patients. Either it is a refractive one, it's maybe topo-guided, wave front guided, laser keratotomy, of course. All of this have an indication, it's not more than -2, -4, maximum 6 astigmatic cornea, not in all have a predictability. Surgical ICR, not in all cases of like this one. Keratoplasty, of course that we have keratoplasty now, even if it's have many complications of a keratoplasty, the cost is very high. And I think most of the grafts have a very bad quality at these days, which is imported from outside. So the start of the story, that's the patients come for us with many pentacam. I don't know why. That's each doctor that's doing have a new pentacam. I don't know why, and he very upset. And you face a problem like this, you don't know how to rehabilitate such this patient. So firstly, it's very important to have a very good preliminary examination and to give a very good time with these patients for explanation, at least for the nature of his disease, the progression, the advantage, complication of each line of the treatment, any cost implications very important for this patient. Sometimes if he knows that's the cost, for example, of keratoplasty, he can far away. For the slit lamp examination, corneal topography, and of course one of the main job in Egypt, I think it's not in Europe countries or the USA, all of these jobs are optometrists. We have the job of the optometrist in Egypt. So we have many types of the contact lens who can deal with such of this case, either scleral contact lenses or corneal lenses, RGP or a combination of both. So it's surprising for some patient or for some doctors how this contact lens work, for example, with a corneal scar. If you have a corneal scar, how it is a scar. No, if you know that the contact lens work by the tear film like this one, and to modify the irregular one to regular surface, we can know very well the tear film lens act as a lens. Either in this case, for example, the steeper contact lens, it looks like the convex one. And the flatter one, it looks like a concave contact lens. And maybe this is the first paper that I published in the Graves Ophthalmology in 2013. That's to describe the tear film by the OCT under the lens. Under the lens, it's about 60 to 70 micron of the tear film. It looks like as a contact lens. This is why to regularize the cornea, because the most of the visual rehabilitation in the scar not due to like a scar. It is the astigmatism due to irregular cornea from the scar. And the age reflex is about more than 100 micron, and this is the key of success of the contact lens fitting. Maybe some golden rules are fitting, it is not an easy job just to make this one in 10 minutes, but corneal topography may be a starting point, but the fluorescein pattern is very, very important one, at the most important point. Of course, there is no single method or philosophy that's to fit all these patients, but the successful contact lens, not only the vision, to maximize the vision, the successful one as to feel the comfort with these patients for many hours every day. Contact lens glossary, it is not an easy job. Again, this is the job of optometrists outside Egypt, but this is our job in Egypt. It is not an easy way, not attractive for each doctor just to make this job, but because this is mainly master degree, I don't want us to say from how much years, but I have many trial sets of the contact lens, and you should know very well all the glossary. Base curve, diameter, power, optical zoom, peripheral curves, aspherical or not, surgical depth, edge left, decay, diffusion constant. It is not an easy job. So, but maybe this is a straightforward case. The fitting in the steps, we have a 3-point touch like and this one. This is very straightforward, the keratoconus, and we have what's called the 3-point of fit. Evaluation is very important after to make this fitting, according to position, lens movement, visual acuity, residual astigmatism, patient comfort, corneal integrity, and also that we discovered that the contact lens per se have, in this paper, have a cross-linking effect. Before the cross-linking, we approved that the patients will wear the contact lens for more than 6 or 7 hours per day. They have less progression than the non-wearer of the contact lens. But of course, the straight roads don't make a skill for drivers. Sometimes we have, like this one, it's very complicated cases, like the scar, like post-keratoplasty, like in a post-index. In all these cases, we use a different design of the contact lens, like Roski IC or irregular cornea, because all these cases, it changed it from a prolate one to oblate one, from a steeper one to flatter one. This is why we can customize a contact lens on this one, to be flatter in the central area and make peripheral steepening and have a very good result, like that's in comparison to the standard RGB lens. Hybrid contact lens also, it's one solution for the cases which is uncomfort with the RGB lens. And this is a paper that's published in the contact lens for surgical performance of the hybrid contact lens. And another solution, scleral one, which is very popular in USA, as it's more comfort because it rests mainly on the sclera. And as you see, well, it's very irregular cornea, but it regulizes the cornea by the tear film. So again, the tear film lens, it's act as an optical lens and making a very good solution for such these cases. This is the result of our study. That's a very high visual satisfaction, and the patient wearing time, it's more than 9 hours per day with very good subjective satisfaction according to visual rehabilitation, glare, halos, diplopia, and the spectacle independence. Always in my protocol, I depend on the contact lens firstly before that's to go with other solutions like the index or surgical problems, because I think it is a very important rule that's to have a simple one and the smaller one, it's very easier than that's to have a keratoplasty these days. So want to shift, if you know that the keratoplasty options have a more than 60 or 70% need a contact lens after the coronary graft, so we can use the contact lens firstly, and we can also shift when it's completely intolerable lenses or fill fitting with all designs. So I think it's irregular cornea is very challenging, but if it well fitted, it appreciates a very good benefits. Fitting of the spacey patients may be difficult, time consuming, but it's very great satisfaction to help someone to have acquire a very good vision. Thank you for your attendance, and give me so pleasure again that's to have the chief editors to Egyptian Journal of Ophthalmology, and I hope that's to publish here. And this is with Dr. Tamer Regal in Frankfurt, making